And for the record, who you're with and your position on the bill.
Yes, Bishop Joe Vasquez, Diocese of Austin, and I speak in favor of Senate Bill 303. Good evening, Madam Chairman and members of the committee. I am Bishop Joe Vasquez of the Diocese of Austin. I'm here on behalf of the Texas Catholic Conference and my brother bishops from the 15 Roman Catholic dioceses across the state to offer our strongest support for Senate Bill 303. I especially want to thank Representative Susan King and her staff for their diligent work to improve this legislation to prioritize the patient while also recognizing the emotional and ethical concerns of the families, healthcare providers, and communities that want to provide the most compassionate care possible. As nearly everyone acknowledges, current Texas law on end-of-life care needs improvement. For example, under current law, the withdrawal of basic care for patients, including food and water, is permissible. Doctors can unilaterally impose do not attempt resuscitation orders without consent or even consultation of patients or families. There currently exists no criteria for determining when treatments can be ended, nor is there a compassionate and structured process of communication and appeal when disagreements arise. Respect and protection of life, starting from the point of conception until the passing into natural death, is as an essential part of our faith. All human life is a gift from God, and therefore innately sacred. In our lives, we strive to live a life that is worthy of our dignity and that promotes the dignity of others. At the same time, our faith respects the individual rights of conscience, especially for those of physicians who cannot impose medically inappropriate treatments that are unethical or inappropriate. We ask doctors to follow their conscience in not performing abortions at the beginning of life. We should not ask them to ignore their conscience when providing care at the end of life. In our vocation as priests and bishops, we are well experienced in witnessing the grief and pain that often accompany the impending loss of loved ones. We see firsthand a culture that has never been comfortable with dealing with death, even though death is a natural part of life. When experiencing that moment with a loved one, only a few of us are truly prepared, either spiritually or emotionally or rationally, for the complexity of moral and emotional decisions to be made. This has become increasingly apparent as medical advances have made it possible to artificially sustain our corporeal bodies, even when doing so may be futile, irrational, or harmful to the person we are trying to sustain. We need a process that allows us to do our best to make reasonable, measured decisions about medical treatments for ourselves and for our loved ones. This is perhaps the biggest step represented by Senate Bill 303, improving the quality and communication and balancing the decision-making process equitably for patients and providers. It specifically prevents the placing of unilateral do not attempt resuscitation orders without notification. It guarantees patients the right to continue provision of nutrition and hydration as long as neither harms the patient nor hastens death. It requires doctors and hospitals to treat all patients equally without regard to physical or medical disabilities or financial status. Most importantly, it recognizes a patient's and family's right to advocate on behalf of a loved one and establishes a clear and balanced process for them to resolve differences before a medical ethics committee. If the dispute continues, families are given 21 days to locate a facility willing to provide the treatment. For some here this evening, the answer to the issues with current law is for surrogates to have the final say and to determine endless interventions on patients without any medical benefit, which can cause harm and prolong the natural death process. Even worse, such a provision takes the decision-making power away from patients, families, and healthcare professionals and injects a government decision into what is one of the most difficult times in life. We believe in the Ethics Committee process as a balanced way to address everyone's concerns. We also believe in the tradition of our church has always taught that a person should be allowed a peaceful death. We believe that this is in conformity to God's will and that God is the one who chooses life and death. So please, I ask you to join us and Representative Susan King in voting for Senate Bill 303. Thank you.
Bishop, thank you for rejoining us tonight. I know that you have some commitments and that you came. I think that Representative Lovenberg has a question.
Yes.
Okay. I'm not Catholic. Do I refer to you as Bishop Vasquez?
It's just fine. Thank you.
Okay. I want to do it, make sure I do it
You're doing it right.
Do y'all meet together, the Catholic Conference of Bishops, and decide, when we're in the legislative session, which pieces of legislation y'all will support, or are you approached? How do you make the decision on what bills you decide to support?
The bishops of the dioceses, which are 15 in the state of Texas Catholic dioceses, we gather together and we discuss these very important issues because we believe that they're going to impact not only Catholics, but they're going to impact also just the ordinary person. So we're always looking at the common good. What's the best for everyone concerned here? And so we're always very interested in making sure that those issues get brought to the forefront and that we're able to advocate and support those particular issues.
Okay. Did you know I saw the bill this session to try and prevent abortions after 20 weeks? Did y'all take a look at that legislation?
Our committee, our Texas Catholic Conference, I believe, looked at that, and I have them here if they would like to respond to those particular issues that you are bringing up this evening.
I had a hearing in State Affairs. Did y'all?
I was not aware of that.
Okay.
Whoa. We'll put a point of order on this bill pretty quickly.
Yeah.
So I'll tell you how we can draw that to an end. If Jody, I think I heard a voice out there that said they, might have registered or whatever. You may approach them out there, and maybe they can talk to you about that.
No one came and spoke. Okay. Thank you.
Thank you.
Representative Hughes or Representative Zedler. And then Representative King. So Hughes.
I can let the authors respond.
Hughes, King, Zedler.
Bishop, thank you for being here, and we know you have a lot of responsibilities, and we thank you. And like Ms. Lovenberg, I'm not Catholic. I do obviously represent a lot of Catholics in my district and many friends who are Catholic, and even those of us who are not Catholics obviously respect the position of the Catholic Church and the what you put into moral teachings and positions, and it obviously means something. So we're glad you're here. Yeah, of course, you were talking about medically inappropriate treatments. I know you haven't been with us all night, but earlier, Dr. Watson, in his prepared testimony, told us that in his written testimony, and I asked him to clarify, but in his prepared testimony, he told us that part of the decision-making process for a physician and these decisions has to do with the dignity of the patient. And of course, you were speaking earlier about the conscience rights of the physician, and of course, we also have the patient's right to life, and those sometimes, occasionally, those conflict. Is it appropriate for the physician when making that decision? Patient wants to continue care, physician doesn't want to. Is it appropriate for the physician to make that decision based on his view of the dignity of the patient, not their physical pain, but the dignity of the patient?
I think that's essential because, you're treating a person. A person always has that dignity no matter what. So no matter how old, how sick they are, the dignity of the human person always has to be safeguarded. And that's ultimately what, we always teach, that the dignity of that person is always to be safeguarded.
And is it the job of the physician or the patient to make a decision as to whether this quality of life is worth living?
Obviously, the patient, along, hopefully, with the physician, together, working that out, being able to determine that. We realize that there is sometimes inappropriate medical care, that attention that ends up hurting the person themselves, and obviously wouldn't want that. So, there's also that medical side as well. So hopefully a doctor will inform the patient very clearly about what they should expect as a result of trying to do that. And also that there's treatment which indeed does not help or ensure life in any way. That is to say, it doesn't really prolong life or help life continue, but it only lengthens the period of time that person will last, but will eventually die. So there's not going to be indeed that protection for that particular person.
I think I understand that. To make sure I'm clear, you're talking about treatment that would or would not extend the patient's life medically?
There's indeed, I think, that particular care, that medical care that's sometimes given by doctor that doesn't prolong life.
Okay.
That definitely is something that we would stand against.
And to put you at ease, I think we can all agree, and the office would agree, that under the current law and under Senate Bill 303, the only thing at issue about withdrawal is life-sustaining treatment. That treatment which would, in reasonable medical probability, extend the life of the patient. So I think we all agree. No one is advocating that treatment which would not extend the patient's life be given. I don't think anybody is for that. So we can take that off the table. I think that will help. That's current law. No one is trying to change that. And so if we have the physician's conscious rights and the patient's right to life, both of which we respect, when those conflict, we try to honor both if we can, right? I mean, is that fair?
Yeah, I mean, that's what you're trying to do, yeah.
Okay. And if we can't, if one of those has to yield, and I know you're an educated man and way ahead of me in these matters, but when one of those has to yield, don't we look at which one was acquired first? We also look at which one, who has the most to lose, right? If my conscience rights have to yield, then I've lost something. But if my right to life has to yield, I've lost a whole lot, right?
Exactly.
Does that make sense?
Yes.
And so when there's a conflict, if we can, we want that right to life to trump that right to conscience if we can't make them both work. Is that fair?
My understanding from this bill is that there is an availability of time period for families to be able to find a location, a facility that will take that patient, and there's 21 days given. The present law only requires 10 days. My understanding is 21 days now is what is being proposed here in this law. I think that is definitely a vast improvement, and that would go a long ways to allow families, those who wish to seek other facilities, to provide that medical care for those persons to seek that out.
So we try to accomplish both if we can.
If we can.
And when the law was put in place, it was thought that 10 days would be enough. We learned that's not enough. Now, when this bill was originally filed, the time was extended from 10 days to 14 days. And I don't have my notes in front of me. Did the church did the Conference of Catholic Bishops take a position when the bill was 14 days?
I did. I think at that time, again, we were looking at seeing how we could bring about some kind of a compromise, and we looked at that. We studied that. For 21 days, we were willing to say that's good. It's a good thing.
14 was good, but 21's better.
I think 21 is better.
Okay. And if I were to represent to you, Bishop, that since 2005, with the scores of families that have testified under oath, sitting where you're sitting, the scores of families that have testified have told us, in the vast majority of those cases, that we're able to try to find a transfer, 21 days was not a long enough time. Would that affect your analysis if you knew that in those cases where a transfer was effectuated, but it took longer than 21 days? Would that affect your judgment in this matter?
You have to look at those particular cases. I don't know that, so I'd have to really study those cases.
I know I'm asking you to make a logical leap, but assume, arguendo, I'm telling you the truth.
Yes.
You can find out I'm a liar later, but if that were true, if there was a lot of testimony that we found a transfer, but it took longer than 21 days. We got it done within 60, within 45, but it took longer than 21. If I could show that to you, would that affect your analysis?
I mean, I would be able to study that, but I still think this bill is good for the 21 days.
So I got that, but if I could show you that there was sworn testimony.
We're not going to move on this, so I know we're not going to be able to.
I'm just trying to understand.
We're engaged in this, but we're not going to move on this, so I understand that. But I respect that.
Okay, thanks. And then finally, we talked about how we, as pro-life people, we obviously wouldn't want a doctor to be forced to perform an abortion at the beginning of life. I think I got it right. He also talked about we wouldn't force a doctor to provide care against his ethics at the end of life. Now, we're not saying those are morally equivalent acts, are we? Taking a life versus providing care that the doctor might not be comfortable with, those aren't morally equivalent positions.
Obviously, the superiority of life, that's vulnerable, defenseless, and it needs protection.
Okay, that's what I thought. Thank you, Bishop.
Okay, Ms. King, then back to Mr. Zedler,
Madam Chair,
and then we're going to wrap this part of the...
I have a quick question for you.
Yes.
Representative Hughes mentioned, and maybe I'm just out of the loop on this, that scores of people have given testimony under oath. Is that in a committee hearing, are you saying? And they're swearing an oath? I wasn't aware of that.
Would you like to?
When a witness testifies, signed, in the old days, signed a witness affirmation form, or today clicks that button there saying, I'm giving this testimony
And that
under oath.
says it verbally in the testimony,
Well,
in the WAF, doesn't
The
it?
form. Oh, yes, ma'am. Yeah.
So, we can get your witness affirmation.
I just didn't know that was a sworn oath.
Yes,
in the
I
form.
mean, it's testimony under oath.
Okay.
It is. And so the first hearing was 2005, and then tons of people came, and then there were hearings again in 2007, 2009, 2011. So those are the hearings I'm talking about. But actually, let me be precise. After 2005 was in the interim, it was actually 2006. But so over the course, at least since 2005, there have been a lot of folks who come testify and under oath. And just like the bishop did.
Yeah, even in the interim when they sign a form. It's
Okay, and thank you. And I wanted to ask Bishop Vasquez a question. And I think this is maybe the third time I've heard this reference this evening, and that is the term natural death. Can you define that for me?
Natural death would be obviously the natural processes that go through someone as they prepare to enter death. Anything that's happening in the body naturally, that is sickness, that's beyond anything that we can do to prolong life or to sustain life in a healthy way. And so that is natural. That's just part of the natural process.
So would that preclude or include, or would it be irrelevant with regards to different type of life-sustaining machines or technology or whatever people would refer to?
I think so. I think we have here treatment that hurts or heals, and that is very important. So anything that's hurting, that hastens death, obviously something that's wrong. Anything that exacerbates major medical conditions, that outweigh the benefit, obviously also is wrong. Anything that causes substantial pain in the person also is something that we would stand against. And if it's medically ineffective, that is to say, this treatment is not going to be able to make a difference in this person's life, prolonging it or moving forward in life.
And one more quick question. How would you define dignity in the framework of all of this? I know that you've mentioned it, but I think it's a subjective term, but I'd be interested in your comment about that as a bishop.
The dignity of the human person is given to us by God. So it's not measured out by color or language or culture or money or anything. It's something that we all have inherently given to us by God. And it's not even whether you're very young or very old, sickly or disabled, the dignity of the human person is still retained in that person. So therefore, the person's always going to be appreciated at whatever stage of life they are, whether it's prior to birth or whether it's as they draw closer to death.
So if it's God-given, then would you agree that an individual would not be measuring that in their decision to make a recommendation on a treatment decision?
I think yes. I mean, definitely we look at the dignity of the human person. We're always trying to protect and ensure that as most as possible.
But would that be a decision point in looking at the physiological treatment decisions that are being discussed within this bill?
Obviously, I'm looking at the dignity of the human person. We have to look at that and take that into consideration as well.
Thank you.
Okay, and then Representative Zevlin for a closing question.
Let me ask you this. I'm a little puzzled because you seem to be kind of fixated on the 21 days, and if testimony suggests that 21 days is not enough, why would we settle for 21 days?
I mean, I think that's definitely a fair amount because we've always looked at the situation of each of the patients, and you're telling me now that that is not.
Right.
So, I mean, I'm saying, at least the information that I have, says there seems to be sufficient time here.
Where'd you get that information?
From my conference, the Texas Bishop Conference.
Okay, and where did they get their information?
We also have the Texas Catholic Conference. The persons who work for us, they're the staff, and so they've also studied this and looked at this.
Okay. When it seems to conflict so much with what people who actually... Let me ask you this. Has the Catholic bishops ever helped people transition going from hospitals to some other facility so that they aren't starved to death, or they aren't... Have y'all ever done that?
I'm not aware of that. I couldn't speak to that. I'm not aware
Why wouldn't we listen to the people who do that?
I'm not saying you can't listen to them. I'm just
Well,
saying.
I mean, and they tell us
I'm
that
not
21
saying
days. And they tell us that 21 days isn't enough.
No. I mean, that's something obviously that y'all will have to decide if you were here advocating for.
So 21 days is not necessarily that. I mean, that didn't come down, and I mean,
it's not in Scripture. I can tell you that. You can't find that in Scripture.
That's right. I didn't take.
I can tell you that. You won't find that in the Bible.
I didn't think it came down from outside.
You're correct about that.
So, I mean, why wouldn't we go for the number of days that people who do this come up with and suggest that this is a better time frame, especially when you're dealing with someone's. I mean, were you here when they had Miss Davis and Miss? Let's see, what was her name? Miss Lopez.
What time was that? I'm sorry. I was out of town, so I had to rush back here.
You might. Well, basically, what they were talking about is how the hospitals fought them every step of the way. And when they were trying to get the people transferred, they got zero help from the hospitals. And you know, to me, 21 days when you get zero help, maybe we ought to go with some other formula. You think?
I don't know.
Okay. And finally, again, do you think we should have it where the patient's consent is needed before they put a DNR in?
See, I mean, yeah, that should be worked out definitely with their physician. That should be worked out.
Yeah,
with them.
but do you think the patient's consent ought to be required?
Well, I mean, according to the bill here, that's decided between the patient, discussing that with their
Well,
physician.
yeah, but no, the bill says basically that they tell the patient verbally, but the patient's got to respond in writing, and it says if the patient's comatose, that there's a reasonably diligent effort made.
I think the doctor there has to take into consideration all of that. It's a very complicated situation. I won't say that it's not, because it's going to be very difficult for that person to make that type of decision. Thank you. You're welcome.
Okay. Thank you very much for coming back.
Thank you,
Bishop. We appreciate it.
Thank you.
Your time tonight. Okay. Robin, I just want to remind everyone that we have 58 left to testify. And so while we've had some great testimony in the first almost 20 witnesses, we are going to pick up the pace. And so we really are going to see the sunrise. So not to focus on you, but we're going to start a new beginning. We talked about Scripture, the Alpha and the Omega. We have the beginning. We're going to look toward the end after 58 witnesses have testified. So, Ms. Chandler, state your name for the record, who you're with, and your position on the bill.
I'm Robin Chandler, Policy Specialist at Disability Rights Texas, a federally mandated statewide protection and advocacy agency for people with disabilities in Texas. I am here in opposition to this bill on behalf